Welcome back to the Change Physician Podcast. I am Melissa Cady with my awesome co-host, Dr. Kevin Cuccaro out of Oregon, and I am in Texas, so not quite both coasts, but I'm kind of halfway in there. That little place called Texas where everyone was making fun of us because we didn't know how to deal with the snow and we had no water, and you got my drift. We're here today for a little host chat that we like to do occasionally with just the two of us talking about various topics. And today we wanted to talk a little bit about this idea of when we don't know the answer as a physician. So people have different philosophies about it, and I think it might be interesting to just kind of bridge the topic so that maybe we just be mindful and aware of this kind of dilemma sometimes with patients. Do you want to tackle your perspective, Kevin, on this issue that doesn't seem to be brought up a lot?
Of when you don't know what to
what would you do?
Well, I guess the number one thing I think about when you have this question is, well, what do you do when you don't know? Is, well, how you flip it is then you go, well, what do I absolutely know? Like, what do I actually know, right? And from a clinical standpoint, and this actually is relevant to a lot of different things, but knowing what you don't know is as important in a lot of scenarios as knowing is knowing what you should know, right? Mm-hmm. So if you're in the absence of knowing something, if you can be pretty clear on knowing what you don't know, in addition to knowing what you know, that's pretty useful. So if a patient comes in and asks you specific questions about whatever the latest fad diet is, or maybe a new medication, or maybe prognosis, or what they're thinking around some new process that is being discovered, if you don't know the absolute answer, the positive answer, if you're pretty sure of what the inverse of that would be, that's pretty useful, and I guess that comes from the pain world, because in my practice fundamentally changed once you recognize sort of, this is going off topic in the whole pain thing, mm-hmm. that how we traditionally approach pain in the medical system is completely backwards and wrong and doesn't actually align with the science. And what that does, though, is allows you to sort of expand and recognize, well, in this scenario, rather than trying to fight quote unquote causes when it comes to pain, because that becomes almost impossible when you understand the complex neurophysiology of that process. It becomes critically important that you recognize, well, what isn't a contributor into this disease process? And so that switch away from, well, I don't have to know the exact answer, but what I need to do is be able to rule out these things, right? Mm-hmm. Be positive in what I that isn't present here. And then in the absence, if you don't know that the perfect answer, then if you can exclude those horrible things or those bad things or the big things that we as physicians have control over, you've accomplished quite a bit. So that's a long way to say is, you kind of flip it on its end, is if I don't know the exact answer to this, well, what is it that I do know, right? What is it that is within that circle that may be important to either rule out or rule in or whatever, rather than pursuing that one perfect answer, which most often we're never going to reach.
Right. And it brings up this idea of the psychology behind also the presentation to patients. If you're going to a physician, is the reality is there is sometimes some uncertainty until you do further workup or further assessments and whatnot. But you don't want to, it's one of those things that you want the patient to trust you, that you are competent and confident that you will find some kind of answer or guide them or tell them what they don't need to worry about, all these various nuances. I think that's where there might be debate on, sometimes I find that there's a little bit too much confidence and bravado that comes across, and I speak from just seeing sometimes surgeons, and you talked about the pain world, and a little bit too much confidence and I'll be able to take your pain away, or this will work and this will help you. And it gives them hope. And that's what patients want. They want some level of hope and confidence that their problem will be alleviated. But I think that's a big setup for potential failure and a catastrophe and a very angry patient, especially if you over promise and under deliver. And what do you think about that?
No, I completely agree with it in the fact that when you're overly confident in something that you shouldn't be overly confident in, that's a big deal. Because again, we're both from a pain background, right? And so you have the super complex process. And then if you're looking at the data for most of the interventions, including surgery, injections, all that stuff, it's pretty garbage, right?
Mhm.
And so if you have, so you have to step back with your kind of physician scientist lens and be able to willing to critically assess the current state of your specialty and appreciate that and not ignore it and pretend it's not there. And then if you have a procedure or something that you are choosing to then perform, that may or may not, I know what my answer is. If you strongly believe in that process or in that intervention, despite what the evidence states, then you need to present it in such a way that you're appreciative of that data rather than saying, well, this is guaranteed. I know this is going to work. You don't know it's going to work.
Mhm.
When all the best literature on something like a spinal fusion, you can flip a coin and you're going to have better prognostic value than your opinion, right? So in what we're doing though is that we're being falsely confident in a place when we shouldn't be confident.
Yeah.
And again, I would return it again when we're in this realm of experiential processes, which is pain, which is fatigue, which is, you know, so much of what is we're seeing in the healthcare system. What we need to be really competent in is understanding that underlying process, understanding what it means when we're looking at an experience. And two is then being able to confidently approach that matter in a patient-centered way so that we can deliver humanistic information, we can be therapeutic caring in a therapeutic relationship that we have, and then not be falsely confident in a specific modality, right? And so instead we can say, and you post on this thing is, patients don't want wishy-washy physicians, right? No one wants that. If you're going to buy a house and you get a real estate agent who says, well, I don't know, this is good, this might be good, this, you know, but maybe the house is going to burn down, maybe it's not. I don't know. What do you think, right? We always kind of do that. Well, informed consent means to blah all this information on somebody and then they're going to decide. Except they don't really have all the education and knowledge and experience that we have in order to make an educated opinion. And then you say, well, it's not up to me, it's up to you. That's a disservice too.
Mm-hmm.
But instead you need to just be able to then, well, what is it that you're concerned about here? Like, you're coming in with this. What are the things that we need to rule out? Again, from a pain standpoint, one of my absolute favorite questions, what about this concerns you or is frightening to you or is scary to you? Right.
Mm-hmm.
And then once you've done that, we can whittle it down. Well, I'm scared of cancer. Well, that's pretty easy to exclude. I'm worried I'm going to end up in a wheelchair like my grandmother. Well, that's a pretty easy thing that you can pretty much assess relatively quick if they're walking into the room.
Mm-hmm.
You know, I'm worried that I have this horrible neurodegenerative process like ALS because I saw those people on the water bucket challenge or the ice bucket challenge and it terrified me.
Mm-hmm.
Well, that becomes pretty easy to exclude too. And then you could be confident in those exclusions rather than to be falsely confident in an intervention that the data or whatever may not necessarily justify you doing. So,
Right.
and you're providing benefit to the patient because you're not doing this wishy-washy stuff of, well, I don't know, or and that leads to a whole different topic of where I think there's, in a lot of ways, physicians have been taught that we're not supposed to have opinions anymore. And I think that is absolutely garbage too.
Yeah. No, I think that it also highlights the importance of listening to your patient, understanding why they're really coming to you, addressing those concerns and, you know, those fears, and impressing upon us that sometimes, you know, it's not about doing something to a patient. It's, you know, it may be just kind of guiding them, coaching them, giving them your, you know, professional opinion of what you think might be the ideal thing to address those concerns. Rule out red flags, or and doesn't mean that you have 100% certainty from the get-go, because it might require some time. And like you said, there's these emergent phenomenon like, you know, pain, stress, you know, some of these traumas, all these different things that you might have to work through some potential contributors and other things and figure out what works best for that patient. But if you give them some kind of, you know, if you give them too many options, just like a lot of us, if you have too many options, it actually is overwhelming. If you can take your professional understanding of things, give them, you know, if there's a couple options, you can give them the pros and cons of this and what you've seen and guide them based on that. And they can decide what they're comfortable with, but they're not necessarily making the decision all by themselves. You're kind of being that coach, guide, professional opinion. And, I think that they're coming to you because they want an answer, obviously. And we may not know what's best for them or what the exact answer is. If it's not just some basic rule out a red flag, it might be that we have to dig a little deeper and understand them in order to help provide better answers for them. And sometimes it takes time because you have to do the try this, see if it helps kind of thing. Not with high risk, of course. There's a lot of other things that can be done other than these invasive, not always, it depends what it is, but definitely on some of these lifestyle things. I'm speaking in very vague terms, but if they're bleeding out, that's a different situation than some chronic ailments. So
that you touched on a bunch of different things, like choice architecture. Like, how do you frame choices in such a way that you're guiding your patients to really what are the better scenarios? So some people, well, that's unfair. Well, again, like you said, if you're overloading them with 65,000 different choices, and we also recognize that the human brain is going to latch onto certain keywords. And then if you give them 65,000 different questions, you may actually have them choose the one that you don't want them to choose. That actually can cause harm. And then the other part is this difference between, like you're talking about bleeding out, acute care versus something that is more chronic and persistent. And we are really, really good in our traditional healthcare system with acute processes. It's sort of like what the whole system has been designed around. We have the best trauma medicine in the world because that's what we're good at. But that's not what most people are going to see your doctor for. Most of us are going in because of these chronic conditions, and for that we do really, really bad. Like it is, we do pretty much, we're pretty atrocious. And the reason for that, and I think we've talked about that in previous episodes, is when you have diseases that are diseases of lifestyle and behavior, the treatment isn't poking them, cutting them, drugging them, more and more lab work all the time. It comes down to identifying those underlying lifestyle and behavioral choices, and then facilitating change there, which is not something that we've learned. The vast majority of physicians have not learned that skill set, which is why we talk about that, why there's entire podcasts that are talking about the soft skills that are in this realm for medicine. Recognizing that everything that walks in, if we only have a hammer and we're just hammering the hell out of everything, you got to recognize when it's not a nail that's walking in. And most of the time, 80% of the time, in most situations, what's walking in isn't a nail to be hammered. Right. So how do we recognize that? How do we then adjust with it? How are we looking at the choices that we're making? How are we looking at the information that we're delivering to our clients and patients in such a way that we're providing them benefit through that choice architecture rather than overwhelming harm? It's the same thing with the wishy-washiness. It's like people are, if you're scared, uncertain, you don't know where to go next, you're looking, something is distressful for you. So we're walking thinking that what we want is a diagnosis, but realistically what we want is reassurance. And the other thing is we want to exclude those bad things. Right. And in the absence, if we have reassurance and we exclude those horrible, awful, super scary things, which are not that hard to exclude in medicine, then most people are comfortable with that level of uncertainty. Hey, I don't know exactly what this is, but with time, you should improve. And we know it's not this and this and this and this. And if it doesn't, you come back and see me again. We're pretty sure. Well, what's the cause? What's the cause? Well, we don't know. There's a lot of different things, but the most important thing is what it isn't, and that's what I'm pretty sure of. Right. And there will be a set of individuals that won't be as beneficial to. You can look at that almost from a trauma lens, because then people who have had a strong trauma background and that kind of what I call high threat sensitivity in those individuals, then that reassurance piece and the exclusionary piece becomes even more important. And those people may not, like, if you're concerned, call me. Instead, for those individuals where we want to kind of keep a tighter look and we want to make sure that we keep that relationship, it takes, I'm going to schedule you to see you in 2 weeks. And then when you're feeling better, feel free to cancel that visit. That's a very different frame. And again, we're moving and we're adjusting to the individual in front of us, recognizing that past history, and then how it impacts the choices and needs that they have in the encounter in the now.
Yeah. Well, you just hit a whole bunch of stuff there.
This is the problem with
Yeah.
with our conversations. They end up going all over the place.
Sure. No, but they apply, and you think about, we talked about before that there's a reason we have research, because there's a lot of uncertainty of what the most ideal approach to certain treatments are for patients. And then on top of that, the caliber and quality and effectiveness, or I would say usefulness, of some studies can be questionable at best on some of those. So it's like, we don't really think about it, but the reason we do research is because we don't know everything, and there is some ambiguity, and you have to know the patient, and you have to kind of work through those soft skills, like just more of the cognitive and emotional aspects to people. And that's not as straight, in the traditional mainstream medicine and how the system has been run. It's very cause effect, do something to people, and it's not suited well for chronic disease. And so that obviously has to change, and there's some efforts to do that, but I think it's going to be a hard sell to change the ways of which we have been trying to apply acute medicine to chronic type disease medicine. And so trying to walk that fine line where you're trying to help the patient be reassured, understand that there is some ambiguity in medicine, and it takes a relationship to kind of help guide you, and then rule out the obvious main big stuff. I mean, that's something that I think there's an art, is what I'm saying. There's an art to this. And like you've said in many other episodes, that awareness that this is an issue that can, even one particular word could set a certain patient off based on how you're saying it, based on their fear of something. And you may not understand that yet. I think just having an awareness to recognize that this is something that can affect your relationship with your patients.
Well, and that returns almost to the beginning. We were talking about sort of that confidence and choice, and what do you say when you don't know, is being comfortable recognizing what you don't know, and still being confident in despite that. And I think that's sort of the difference between maybe early practice physicians and later practice physicians, is that as you get more experience, you're more comfortable saying you don't know, because maybe, I'm just kind of imagining it, maybe it is a less of impact because, when you are first starting out and you're hot shot or trying to prove yourself or whatever, there's a fear and vulnerability as a physician on there that if I don't know, or if I say I don't know, or if I'm asking for help, it's going to make me seem like I'm less, how are these people going to judge me? And we all know there's a lot of judgment that goes on in medicine. Let's not pretend that doesn't occur, because it sure does. Yeah. But as you get older, you kind of recognize again what's important, what's not, and you feel much more confident in saying, "Well, I don't know exactly what this is, but I know what it isn't. I know this, and that becomes important, because one of the most dangerous things, we should do an entire episode on this, is being falsely competent and not being able to recognize when you don't know something. That, of course, that's a loaded issue, because then we can get into care models and everything else. But if you're just blithely going through the land thinking everything is super easy, this is not complex at all. Oh, I walk in and I can just prescribe the same thing for the same cough, cold, congestion or whatever. Well, there's probably a lack of awareness there on the complexity of the human condition, and really a lack of awareness of all the other things that we try to learn in physician training, that we at least have been exposed to in such a way that it's sitting on that back shelf. And if you're feeling that little gremlin going, wait a second, something's not quite right here, that's an important sense. But anyway, that's a whole different discussion. It's kind of that expansion of awareness. And as your little circle of awareness gets bigger and bigger and bigger, obviously the surface area gets bigger and bigger and bigger. And then you're more aware of all the stuff that you don't know. So then you fall in this conundrum, is because the more you know, the more you don't, you think you don't know, because you're not recognizing all the stuff you do know. And yeah, we can start about, Dunning-Kruger and all those kind of curves and stuff. But we should probably not go into that right now.
No. Well, I thought we circled around quite nicely, not too far off on a tangent, and the nuances are important, and the art of understanding this complexity of how you're interacting with the patient and expressing confidence and competence and understanding yourself and what you know and don't know. I think all those are relevant for us to consider and be aware of. So do you want to take us out for the episode?
Sure, I will take us out. And, thanks for joining us today for a host chat for the Changed Physician podcast. This is Dr. Kevin Cuccaro with my fabulous co-host, Dr. Melissa Cady. You can, interested in learning more about the community, go to thechangedphysician.com. You can sign up for the email list there and kind of be informed when the new things that we have in the development process. We'll see you again every Mondays and Thursdays.
Release, yeah.
Well, whenever. I think it's Mondays and Thursdays. Actually, you can join us on Facebook for our live streams when we do Monday motivations, which are always a kick. But until next time, stay well, and we will talk to you soon.
Take care.